Here is a number that should stop every senior with sciatica in their tracks. 90%. That is the percentage of adults over 60 who show significant disc abnormalities on MRI, herniated discs, degenerative changes, stenosis, who have absolutely no back pain or sciatica whatsoever. 90%, which means that when your MRI comes back showing these same findings that look alarming on paper and sound alarming when described, there is a very real possibility that what the scan found has nothing to do with what is causing your pain. Yet every day across America, seniors with sciatica receive MRI reports describing these normal age-related changes and walk out of imaging centers believing they need surgery for findings that most pain-free adults their age have too. Tonight, I am explaining exactly what MRI findings actually mean for sciatica, and exactly what the research says about who actually needs surgery and who does not. And real quick, if someone you know is considering sciatica surgery based on an MRI report, pause right now and send this video to them before they make that decision. What they are about to hear could change everything. And if you are not subscribed yet, hit that subscribe button right now. Every week, this channel delivers honest, research-backed information that could save you from decisions you might later regret. Now let us get completely into this. My name is Dr. Michael Kent, and in 20 years of senior health practice, this is the conversation I have needed to have more times than I can count. A patient comes in frightened. They had an MRI. The report describes herniated discs, degenerative changes, stenosis, bone spurs. They believe something is seriously wrong. They are considering surgery. And what I need to explain, what most busy clinical appointments never have adequate time to cover, is that most of what that report describes is not abnormal. It is not dangerous, and in the majority of cases, it is not causing the sciatica pain at all. Tonight, that conversation happens here, completely. For every senior watching who has ever received an MRI report and felt frightened by what it said. Before anything else, let me share a composite story that reflects what I have seen in practice over and over again across 20 years. The details have been changed to protect privacy, but the experience is one that thousands of seniors across America will immediately recognize. A patient came to me, a retired professional in their late 60s, who had been dealing with right-sided sciatica for approximately 8 months. The burning shooting sensation running from the lower back down the leg had not responded meaningfully to physical therapy and over-the-counter pain management. An MRI was ordered. The report came back describing a herniated disc at L4 to L5 with mild nerve root impingement, moderate degenerative disc disease at 2 levels, mild foraminal stenosis at L5 to S1, and facet joint arthrosis at multiple levels. The radiologist's report used clinical language that sounded alarming to someone without a medical background. The patient arrived at my office convinced they needed surgery. They were frightened. They were already researching surgical options online. I sat with them and asked one question before we discussed the MRI at all. On a scale of 1 to 10, how is your pain today compared to 3 months ago? They thought for a moment. About the same, maybe slightly better on good days. I nodded. Then I showed them a study, and everything changed. That study, published in the American Journal of Neuroradiology, is one of the most important pieces of research ever conducted in the field of spine health. Researchers took a group of adults with absolutely no back pain, no sciatica, and no spinal symptoms of any kind. They gave every single one of them an MRI, and then they published what they found. In adults over 60 with 0 pain and 0 symptoms, the MRI findings were as follows. Disc degeneration was present in 93%. Disc height loss was present in 68%. Disc bulging was present in 81%. Disc protrusion, what most people call a herniated disc, was present in 38%. Facet joint degeneration was present in 83%. Foraminal stenosis, narrowing of the spaces through which nerve roots exit, was present in 21%. These are adults with no pain, no sciatica, no symptoms, whose spines look on MRI almost identical to the spines of people who are in significant daily pain. This finding, replicated across multiple subsequent studies with consistent results, fundamentally changes the way the most evidence-based pain specialists in the world interpret MRI findings in sciatica patients. The findings on your MRI are not a diagnosis of the cause of your pain. They are a photograph of your aging spine, and aging spines look like this in almost everyone, pain-free or not. Here is why this matters so profoundly for sciatica patients specifically, and this is the part of tonight's discussion that most seniors never hear anywhere. The relationship between structural findings on MRI and the experience of sciatica pain is far weaker than most people, and many clinicians, assume. Research published in the journal Pain found that the correlation between MRI-identified disc herniation severity and the intensity of sciatica pain reported by patients was poor. Patients with small herniations often reported severe debilitating pain. Patients with large herniations documented on MRI often reported mild, manageable symptoms. The MRI finding does not predict the pain experience, because the pain experience is not determined solely by the structural finding. It is determined by the inflammatory environment around the nerve, the central sensitization of the nervous system, the psychological and social context of the pain, and multiple other biological factors that an MRI simply cannot capture. This poor correlation has a critical practical consequence. When surgery is recommended based primarily on MRI findings, without adequate consideration of whether the documented structural finding is actually the source of the patient's specific symptoms, the surgical outcome is often poor, because if the MRI finding is not actually causing the pain, then removing or repairing the MRI finding does not remove or repair the pain. And this is exactly what drives the extraordinarily high rates of what pain specialists call failed back surgery syndrome, a condition in which patients who had spinal surgery for sciatica continue to experience the same or worse pain after the procedure. Research published in the journal Spine found that approximately 20 to 40% of patients who undergo spinal surgery for sciatica-type symptoms experience persistent or worsening pain after surgery, a clinical outcome so common it has its own medical diagnosis. Failed back surgery syndrome, 20 to 40%. That means that somewhere between 1 in 5 and 2 in 5 patients who have spinal surgery for sciatica, surgery that was recommended partly on the basis of their MRI findings, would have been better off without the operation. Now here is the absolutely critical question. If MRI findings do not reliably indicate who needs surgery, what does? What are the genuine indicators that a sciatica patient actually requires surgical intervention rather than continued conservative management? In 20 years of practice and based on the current evidence-based guidelines from the North American Spine Society and the American Academy of Orthopedic Surgeons, there are 3 specific clinical situations where surgery genuinely and urgently needs to be considered for sciatica. The first is cauda equina syndrome. This is the one situation where sciatica becomes a genuine surgical emergency. Cauda equina syndrome occurs when the nerve bundle at the base of the spinal cord is severely compressed, producing a very specific cluster of symptoms that are completely different from ordinary sciatica: progressive weakness in both legs simultaneously, loss of bladder or bowel control, either inability to urinate or urinate without control, numbness or loss of sensation in the saddle area, the inner thighs, the perineum, the area that would contact a saddle when sitting on a horse. If any combination of these symptoms appears, particularly loss of bladder or bowel control, this is a medical emergency requiring immediate evaluation, not a scheduled appointment, an emergency room visit the same day. Cauda equina syndrome left untreated produces permanent paralysis and permanent loss of bladder and bowel function. It is the one situation where waiting is never acceptable. The second genuine surgical indication is progressive neurological deficit. This means measurable and progressive loss of muscle strength in the leg. Not pain, not discomfort, but actual documented weakness that is getting worse week by week. If a patient goes from full strength in the foot dorsiflexion to significant weakness over 4 to 6 weeks, this progressive loss of neural function indicates that the nerve is being damaged at a rate that conservative management cannot address. Surgery in this context is genuinely neuroprotective. It aims to stop ongoing nerve damage before it becomes permanent. This is a different clinical situation entirely from surgery performed because an MRI shows a herniation in a patient whose only symptom is pain. The third situation is persistent severe sciatica that has failed a genuine and comprehensive trial of conservative management lasting a minimum of 6 to 12 weeks. The key words here are genuine, comprehensive, and minimum. A genuine trial means physical therapy performed correctly and consistently, not 2 sessions followed by self-directed stretching at home. Comprehensive means addressing inflammation through nutrition, movement modification, appropriate pain management, and sleep optimization simultaneously, not one intervention tried briefly before concluding that conservative management failed. And minimum 6 to 12 weeks means allowing adequate time for the natural history of disc herniations to take its course. Research published in the journal Spine has shown that 90% of symptomatic disc herniations reduce spontaneously over 6 to 12 weeks through a process called phagocytosis, where the immune system literally reabsorbs the herniated disc material. 90%, resolving on their own, without surgery. The patient who came to me with that frightening MRI report did not have cauda equina syndrome, did not have progressive neurological deficit, and had not completed a comprehensive conservative management trial. Their physical therapy had been inconsistent and their nutritional and lifestyle interventions had been minimal. We designed a proper, comprehensive conservative protocol. 6 weeks later, their pain had declined from a consistent 6 to 7 to a consistent 3 to 4. 8 weeks after that, 4 months from our first conversation, they rated their pain at a consistent 1 to 2. No surgery, no procedure. The MRI findings that had terrified them were still there on their scan, because they would always be there, because they were age-related changes rather than the cause of their pain. But the pain was largely gone, because the actual drivers of their sciatica, the inflammatory environment, the inadequate conservative management, the central sensitization, had been properly addressed. Here is what every senior watching tonight needs to know about navigating MRI findings and surgical recommendations for sciatica. First, an MRI finding alone is never sufficient justification for surgery. The finding must correlate specifically with the clinical symptoms. The pattern, the location, and the character of the pain must match precisely what the MRI finding would be expected to produce. A radiologist's report is an anatomical description, not a clinical diagnosis. The correlation between the finding and the symptoms must be established by a clinician who examines you in person, not just by the imaging report. Second, always seek a second opinion before agreeing to spinal surgery for sciatica. Research published in JAMA Internal Medicine found that second opinions for surgical recommendations changed the recommended treatment in approximately 21% of cases, with a significant proportion of patients recommended for surgery by one specialist being recommended for continued conservative management by another. A second opinion costs time. Surgery costs the rest of your life if it goes wrong. Third, ask specifically about the natural history. What percentage of patients with this specific finding and this specific symptom pattern improve without surgery over 6 to 12 months? The evidence base on this question is clear, and the answer in most cases strongly favors patience and conservative management over early surgical intervention. Fourth, if surgery is ultimately recommended, ensure that the specific procedure being proposed addresses the specific finding that clinical examination has confirmed is causing your specific symptoms. General spinal surgery for generally abnormal MRI findings is not an evidence-based approach. The procedure must be targeted precisely at the confirmed source of the pain. In 20 years of practice, the patients I have seen recover most completely from sciatica, including patients with significant MRI findings, are consistently those who committed to comprehensive conservative management before accepting surgical recommendations. The 90% spontaneous resolution rate for symptomatic disc herniations is real. The poor correlation between MRI findings and actual pain causation is real, and the 20 to 40% failed surgical outcome rate is real. These numbers deserve to be part of every conversation about MRI findings and surgical recommendations for sciatica. Tonight they were. Share this video with every senior you know who is facing this decision. Now, before you go, drop a comment right now and tell me your age and your city. And tell me, have you ever received an MRI report for your sciatica that frightened you? Were you recommended surgery based on those findings? I read every single comment personally. The conversation in the comments section about this topic is one of the most important conversations this channel can have. Share this video with someone who needs it before they make a surgical decision. Subscribe and turn on notifications. because every week this channel brings you the honest information that most appointments never have time to provide. This video is for general educational and informational purposes only. It does not constitute medical advice and does not create a doctor-patient relationship. All patient stories in this video are composites and have been altered to protect privacy. Any resemblance to a specific individual is unintentional. The information presented reflects publicly available peer-reviewed research as of 2026. MRI interpretation and surgical decision-making require individualized professional evaluation. The general information presented here cannot replace a comprehensive clinical assessment by a qualified healthcare provider. Some patients with sciatica do genuinely require surgical intervention, particularly those with cauda equina syndrome, progressive neurological deficit, or confirmed failure of comprehensive conservative management. Never delay seeking emergency medical care for symptoms of cauda equina syndrome, including loss of bladder or bowel control. Dr. Michael Kent is a senior health educator with 20 years of experience in senior wellness. Nothing here intends to diagnose, treat, cure, or prevent any condition. Always consult your qualified healthcare provider for diagnosis and treatment decisions. Viewer discretion advised.